Okay, I am Dr. Ederson. This is continuation of part one, extubation management. So, we are discussing about the cuff cuffless text. So, generally speaking, it is reasonable to proceed with extubation if the cufflink exists, but to delay extubation if the cufflink is reduced and there are risk factors for laryngeal edema. So, we have to follow. Extubation should be considered on the individual basis, especially if there is like with absent cuff leak but no risk factor for laryngeal edema. Otherwise, all the other indications are good, so we can do laryngeal ultrasonography, and it is simple, rapid, non-invasive way to evaluate the width of laryngeal air column during cuff deflation, thereby assessing the likelihood of post-extubation stridor. Although promising, this modality is not recommended for routine use until controlled clinical trials are performed. So, for patients whose initial trial of extubation failed due to stridor and who are now becoming considered for extubation, one, if the cuff leak is detected, bedside extubation is generally safe. If the cuff leak is absent despite a course of glucocorticoid therapy, so extubation over the airway exchange catheter or Cox catheter is mandatory. So this airway exchange catheter may facilitate successful intubation without delay if there is necessary. So extubation of such patients in a controlled environment such as the operating room should also be considered. The glucocorticoid therapy, there are conflicting data whether giving the glucocorticoid therapy or not. So but the meta-analysis suggests that support this glucocorticoid therapy for at least 4 doses or 24 hours of methylprednisolone, but administering a single dose may not have an effect on improving this stridor or laryngeal edema. We must suggest that patients with extubation is delayed due to reduced cuff leak receive a short course of this glucocorticoid, as I said. For example, methylprednisolone 20 mg every 4 hours for a total of 4 doses can be acceptable. Or we can give a single dose of 40 mg methylprednisolone administered 4 hours prior to extubation. So, um, um, so let's come to extubation procedure. So the patient, you have to put the patient in sitting position. You have to prepare all the necessary equipment, that is oral airway, nasal airway, laryngeal mask airway, endotracheal tube with different sizes for the patient, especially we suspect laryngeal edema with reduced size than the previous. So, and the other is laryngoscope. The other is if there is like as I said previously, so a Cox catheter or a airway exchange catheter or a bougie, and the other is if it is necessary, the other invasive like fiber optics. So after preparing these, other is emergency medications like adrenaline, noradrenaline, atropine, okay, labetalol, and the available emergency drugs and intubating drugs like sedatives like propofol, ketamine, and muscle relaxants like saxamethasone that we can use. So one is you have to put the patient in sitting position after preparing all this and after routing all the extubation criteria. So put the patient in upright position. Both oral and tracheal tubes are suctioned. After suctioning, instructions are given for the patient to take a deep breath and then exhale. During exhalation, the cuff is deflated and the tube is removed in a single smooth motion. Okay, and the other is all gastric tube have to be removed with endotracheal tube. Following extubation, oral cavity is again suctioned and supplemental oxygen is administered by face mask. So hemoglobin saturation, heart rate, all the vital signs, respiratory blood pressures are monitored throughout the extubation process. So a patient with increased secretions may require frequent secretion or mm, so after such type of doing such extubation, then there is a post-extubation management. We have to follow the patient. So the patient should be closely monitored following extubation. In many cases, early aggressive management can prevent reintubation, like early physiotherapy, chest physiotherapy, very, very important. Suctioning, okay, bronchodilator therapy if needed, and the other is diuretics if needed. The other is putting the patient, especially in non-invasive positive pressure ventilation. The evidence suggests that this non-invasive positive pressure ventilation may prevent post-extubation respiratory failure if it is applied soon after extubation. This is key. You have to keep it in mind. Patients were considered at risk for a post-extubation respiratory failure if they were like elderly patients greater than 65 and Apache score greater than 12 on the day of extubation. So these patients, and also if the are required intubation due to cardiac failure, so such reasons have a risk of post-extubation respiratory failure. Non-invasive positive pressure ventilation was associated with lower intensive care unit mortality, that is 3 versus 14%, but not a lower intubation rate. Okay, remember. So this NPPV will not decrease the intubation rate and also will not decrease the hospital mortality or the 30-day mortality. It only decreases the intensive care unit mortality. So predefined subgroup analysis found that the benefits of this NPPV was limited to patients who had like hypercapnia. Remember also this. So, so we use most of the time in those patients who have chronic respiratory problems like COPD and like asthmatic patients. Okay, so in contrast, this appears ineffective and potentially harmful if it is not initiated until after the onset of post-extubation respiratory failure. So, if you wait or if you delay until the patient develops post-extubation respiratory failure, and you do non-invasive visit, so this will be ineffective and this may even kill the patient because this is a terminal time that the patient is in intubation. So the other is a respiratory failure was defined by two or more the following parameters. That means acidosis, pH less than 7.35, the capnography reading PO2 or arterial blood gas PO2 greater than 45. Clinical sign of respiratory failure like use of exercise muscles, okay, accessory muscles like and intercostal subcostal retraction, paradoxical motion of breathing. The other is respiratory greater than 25 breaths per minute for 2 consecutive hours. Mm, the other is like hypoxia, arterial oxygen saturation less than 80 millimeter or oxyhemoglobin saturation less than 90, or FI or need of FiO2 greater than 50%. All cause mortality increased in the non-invasive positive pressure ventilation groups, like 25% versus 14%, resulting in early termination of the trial. So if the patient has such things like acidosis, use of accessory muscles, respiratory greater than 25 for more than 2 consecutive hours, hypoxic patients. So normally we follow patients after extubation, and it is the normal that we use most of the time. Strictly, we have to follow patients for 2 hours. It's the reason that we have to follow for the patients like respiratory rate, so if and hypoxia and pH and arterial carbon dioxide level, oxygen level, all these things. So increased mortality may have been related to delay reintubation. So if you get such things, we have to intubate urgently. Okay, we must not wait, and we must not put the patient on an invasive positive pressure ventilation. Okay, you have to put, well, you have to intubate the patient. So I have to repeat this because it's key, it's important, because patients are dying due to different reasons of missing this management. So respiratory acidosis, if the patient, we have no APG analysis actually, so we can use of respiratory muscle, accessory muscle, intercostal, subcostal relaxation, paradoxical motion of the abdomen. We can use this one, and we can use the respiratory if it is greater than 25 for more than 2 consecutive hours, and pulse oximetry reading less than 90 despite a FiO2 of greater than 50. All this suggests that uh, there is chance of mortality if we delay. So it is meta-analysis study. We have to accept this, and we have to intubate the patient urgently. The increased mortality also may be related to delayed intubation, as I said. In light of this data, we suggest that the patients who have hypercapnia during their pre-extubation spontaneous breathing, they receive an positive pressure ventilation immediately following extubation. This is already has been said. The patients who are significantly hypoxic following extubation may be treated with either a high flow face mask or high flow nasal bronch. High flow nasal bronch are better tolerated and produce some PIP, particularly if the patient's mouth is closed. A trial of NPPB is reasonable in patients of impending acute respiratory failure is suspected. So, yeah, trial, but actually the trial has to wait only for like less than 30 minutes. So you will try for 30 minutes to 1 hour as a patient, and if the patients have failed this, the all trials has been said, that has been said, to intubate the patient. However, patients should be promptly intubated if they either one is failed the trial of non-invasive positive pressure ventilation, the other is develop definite acute respiratory failure before the acute trial of this NPV can be initiated. So we can reintubate the patient before even giving the trial of NPPV, especially if the patient have a definite acute respiratory failure. Outcomes following extubation are related to whether the extubation was planned or unplanned. Normally, generally speaking, outcomes are better following planned extubation. Unplanned extubation is most patients who undergo unplanned extubation should be completely intubated within the date, because delayed intubation is associated with increased mortality. This is probably because intubation after unplanned extubation is often technically difficult, so careful observation is appropriate for only a minority of patients who are clinically stable, who have low ventilatory oxygen requirements, who have patent airway, and who can protect the airway. So, in unplanned extubation or self-extubation by the patient, if the patient only fulfill sorry, or if on the patient only fulfill all such criteria, we can wait. Otherwise, we have to intubate the patient. Clear zero secretion is critical to avoid intubation. Also, unplanned extubation is associated with longer duration of mechanical ventilation, ICU stay, hospitalization, and days compared to the matched control trials. Unplanned extubation occurs in 3 to 12 patients of intubated patients. This is common, and in oral intubated patients than nasally is more frequent when attitude is not well secured. In patients who are also agitated, well not sedated, or physically restrained. Most unplanned extubation occurs within 1 day of planned extubation, prior to planned extubation, and 50% of patients who have undergone unplanned extubation require intubation after or within 12 hours. So reintubation is common following accidental unplanned extubation, and among patients who require full ventilatory support, have high sedation score, and have a significant oxygen requirement, especially greater than 50%, all the previous criteria. The other is um, extubation failure. Estimated that 12 to 14% of patients who undergo planned extubation require intubation. So within 2 to 3 days, most within the first 1 day. So risk factors are, one is calf reflex, weak calf reflex, the other is frequent suctioning, okay, increased secretion. So